17-month-old male who presented to Texas Children's Emergency Department 2 days ago for fever, not wanting to bear weight and refusing to walk, and redness around the left upper leg. Marco's mother reports she noticed he seemed fussy when she changed his diaper over the past few days and didn't want to bend his left leg when changing his diaper. Mother reports he was still walking 3 days ago, however started to have a slight limp and seemed to be dragging his left leg when walking. However, now he's not bearing any weight and refuses to move his left leg. Reports fever started 2 days ago, Tmax 39. Mother gave him a dose of ibuprofen, which helped control the fever. Mother has noticed left upper leg around his hip looks red and swollen and was slightly warm for the past 2 days. She reports he has been fussy over the 2 days, eating and drinking well, no vomiting or diarrhea. Mother was concerned due to him not wanting to bear weight and fussy in the swelling of his leg, which prompted her to bring him into the emergency department. Mother does report a cough and runny nose approximately 10 days ago, however, reports symptoms have resolved. Patient is drinking well with 6 wet diapers a day, denies any rash other than the redness around his hip, denies any recent known injuries or falls or trauma. Mother denies any history of known MRSA of the patient or in the family. Patient was full-term vaginal delivery without complications. Patient lives at home with his mother and father and older sibling. Denies any smoking in the home, denies pets, denies any recent travel, and patient is up to date on all of his vaccinations. Denies any prior hospitalizations, denies any prior surgeries, and patient does not take any daily medications. The only medication he has been taking is the ibuprofen that mother has been giving to control the fever. So ED presentation. Upon presentation, the ED patient was alert and fussy on exam and age-appropriately resisting exam. He had flushed cheeks and was slightly diaphoretic. Patient was lying on the exam table with his left leg held in a position of flexion, abduction, and external rotation. He is very fussy and cries when his left leg is assessed and when trying to be repositioned out of the position he's holding it in. Patient with decreased range of motion of left hip, and he's very fussy when performing range of motion. Left hip has some redness and is warm to the touch, and there's mild swelling of the left hip and upper thigh compared to the right hip. When held in a standing position, patient is fussy and keeps his left leg flexed and abducted and refuses to bear weight and cries. His vitals in the emergency department: temp 39, heart rate 178, respiratory rate 26, blood pressure 112/70, and SATs 99% on room air. So in the ED, AP and frog leg lateral hip x-rays were obtained in the ED. Left hip reveals widening joint space in the hip with a slight joint effusion, but no fractures or obvious signs of osteomyelitis at this time. Due to concerns for septic joint, orthopedics was consulted. Orthopedics came to and evaluated the patient and recommended an admission to rule out septic joint. Orthopedics recommended obtaining a CBC with DIP, CRP, ESR, and a blood culture. The white blood cell count revealed was 20 with a left shift. The CRP and ESR were both remarkably elevated as well. CRP was 14 and ESR was 68 with blood cultures pending. So patient was admitted to the orthopedic service where an ultrasound was obtained. The ultrasound revealed a large joint effusion with thickening of the synovium. Patient to be NPO for surgical debridement and irrigation of hip and joint aspiration by orthopedics that evening. An IV was placed, an NS bolus of 20 mils per kilo was initiated, and maintenance IV fluids was initiated since patient was NPO at D5/2 NS at 40 mils an hour. Patient was taken to surgery that evening for hip aspiration. Fluid samples sent for white blood cell count, culture, and gram stain. The joint aspirate of fluids revealed 58,000 white blood cells. Empiric antibiotics were initiated after blood culture and joint fluid obtained to appropriately cover MSSA, strep pyogens, and K-J. Oxacillin 50 milligrams per kilogram IV Q6 hours was empirically initiated to provide coverage for Staph aureus, which is the most common in this age group. And clindamycin 10 milligrams per kilo per dose every 8 hours was also initiated for coverage of gram-positive organisms and anaerobes as well as MRSA coverage. So upon assessment, patient is 10.2 kilos, his heart rate was 140, respiratory rate 24, temp 38.1, blood pressure 98/62, and 100% on room air. Patient was lying on an exam bed in the hospital, awake with mother at his side, slightly staff anxious for his, but age appropriately and consoles easily with mother. There's no acute distress. His head is normal cephalic, external ears are normal and TMs are normal, nose clear, no rhinorrhea, mouth moist mucous membranes, no erythema, edema, or exudate, and normal dentation without any obvious cavities. His eyes are conjunctiva without erythema or discharge. Pupils are round, equal, a 3+ bilaterally, and reactive to light. Normal range of motion of neck. Cardiovascular wise, he has normal rate and rhythm. No murmur noted. Pulmonary lungs are clear, no retractions, and patient is on room air. His abdomen is soft, active bowel sound, and does not appear painful with palpation. Musculoskeletal, left leg is immobilized and splint. Patient does guard and start crying when leg is trying to be assessed, acting as though he's fearful. There's a dressing over the left hip with a scant amount of serosanguinous drainage. There is a drain in place under the dressing and a scant amount of drainage as well when the dressing is lifted. There's no redness or warmth or signs of infection, and there is mild swelling of the left hip and thigh. Neuro-wise, patient is alert and age appropriately. Resisting exam. Skin warm and dry, no rash noted. IV in place in his left hand, and there's a PICC line in place in his right arm. The IV central line has no drainage. So problem list for him: health maintenance, joint effusion, fever, septic arthritis, inability to bear weight, risk for infection, tachycardia, differential diagnosis, septic arthritis, osteomyelitis, transient synovitis, leg fracture, joint effusion, leg calf press disease, juvenile idiopathic arthritis, and pediatric serum sickness. Impression: this is a 15-month-old male with fever, irritability, inability to bear weight, redness, and swelling of left hip that started 3 days ago. Ultrasound and lab findings are consistent with septic arthritis of the left hip. Patient was admitted, taken to the OR for urgent arthrotomy and open drainage of the left hip, and IV antibiotics were initiated for empirical coverage until organ is identified. Patient is stable at this time, however, will continue to monitor for signs of infection, vitals, and follow labs closely. Patient will remain on IV antibiotics. Assessment and plan: continue to monitor surgical site and monitor for signs of infection. Continue to monitor vitals and for fever curve. Manage pain: Tylenol 12 milligrams per kilo scheduled Q6 and morphine 0.1 milligrams per kilo Q4 hours PRN for breakthrough pain. MRI is to be scheduled 2 days after the surgery to evaluate for potential osteomyelitis. Typically, lytic changes and periosteal changes take place 7 days after symptoms start and often aren't seen at the beginning of the disease, so an MRI was decided to be done. Obtain a daily CBC with DIF, and CRP and ESR are Q Monday, Wednesday, Friday. Patient to start with clear fluids after surgery, and advanced diet is tolerated. Once the patient is tolerating fluids, we can decrease the IV fluids to keep PICC line patent. Monitor and maintain bowel regimen, Colase 25 milligrams PO daily as needed. PICC line due to long-term course of IV antibiotics. Consult infectious disease, recommends to continue IV antibiotics once etiology is known for 3 weeks until CRP and ESR are back to normal and symptoms have resolved. Then continue an oral therapy for another 3 weeks at home. Consult occupational therapy and consult physical therapy to start working on passive range of motion 3 days post-operatively. Consult Child Life to help child remain comfortable during lengthy hospitalization and help provide support to family and older sibling. Consult social work to help family with financial or social concerns during their hospitalization. And follow up with all pending cultures and sensitivities. Discuss findings that I do to make sure appropriate antibiotic selection will cover organisms. Staph aureus is the most common in this age group, and oxacillin should provide appropriate coverage. However, if MRSA is of concern with gram-positive organisms, then clindamycin may be the appropriate choice as well as to go home with. Once discharged, patient is to follow up in the ortho clinic in a week to continue to monitor his progress and to obtain repeat inflammatory markers, and then again 1 week after stopping antibiotics, patient also needs repeat labs and to follow up in the orthopedic clinic.